right, let's call the meeting to order. Happy Valentine's Day, everyone. And if anybody has forgotten about that, you might want to get to the store. It's getting picked over pretty quickly. So, okay, I've been told there's no citizens wishing to address the committee unless that has changed. Okay, so we will go to the next order of business, employee recognition, the Dr. Charles Weber Golden Mitt Award. I didn't realize that we had a celebrity on the board, but I guess we do, so. I know.
All right, next slide. I'll lead us through these presentations. So you may, folks may recall that back in December, we named our Golden Mitt Award after Dr. Weber. This award recognizes units around JPS who have shown a particular commitment to patient safety. And so we're doing this somewhat in lieu of the previous Innovation Quarter presentations that we had, because we do believe it's very important to recognize outstanding units and outstanding programs at JPS. But we thought this would be a good way to highlight some of the good work that they're doing. The first group that we'd like to recognize, and we have Bobby Coleman here, their manager, to be in person for the recognition, is Invasive Labs. So what we're going to do is every quarter, since we're meeting quarterly, we're going to present 3 of these. So because we give this award out each month, so we'll cover each previous quarter's award winners. So this goes back to November 2021, Invasive Labs. So it's with great pleasure that we announce the recipient of the November Golden Mitt Award was our Invasive Labs department. They were actually nominated by our Infection Prevention Department. They have been instrumental in developing processes around high-level disinfection of ultrasound probes, for which we were recognized as best practice by the Joint Commission. They have been very instrumental in helping us investigate central line insertions and CLABSI prevention, and they have been awarded a number of good catches for preventing patient safety events in their area. And so for these efforts, in November, we recognized Invasive Labs as our Golden Mitt Award winner. And so if we can recognize the Invasive Labs team and Bobby Coleman, who's there, with a round of applause.
Bobby, who do you have with you here?
Right, I have one of my MST team. She is one of the top performers in the process that we have, high-level disinfecting processes that we have, and she has taken it on because it was something that was kind of thrusted upon us, and we carried it on and done well with it, and she is one of my top team members for that.
Okay, thank you. I'll have to take note of that.
If we could go forward to the Tower 8 slide. Are we there? I can't actually see the slides going forward, so.
Yeah, we got you, Dr. Stevens.
Perfect, thank you. So in December, we recognized Tower 8. So it is with great pleasure that we announce the recipient of the December 2021 Golden Mitt Award to Tower 8. They were nominated by our Clinical Risk and Regulatory Affairs Department. The Tower 8 staff members showed their commitment to keeping patients safe over the last few months, especially in the reduction of falls in the med-surg units. And they have also submitted a good number of good catches as well, showing their commitment to patient safety. And here to be recognized for Tower 8, I believe, is Cynthia Garcia. So if we can go forward to the next slide with the photo of their team.
So
Recognized.
this is to let you know that they are very busy on Tower 8, and we're not able to break and to come down, but we can go ahead and at least recognize them for the great work that they're doing. So.
Excellent. And let's go forward now to the cardiac monitoring slide, which should be the next slide. So Officially, the cardiac monitoring unit is the first winner of the Dr. Charles E. Weber Jr. Golden Medal Award since we updated the name in December. So it's with great pleasure that we announce the recipient of the January 2022 Dr. Charles E. Weber Jr. Golden Medal Award. So the cardiac monitoring department, which is also known as our war room. So these are the people who keep an eye on all of the EKG strips around the hospital that are going on in our patients who are being monitored remotely. They have made amazing strides over the last several months working behind the scenes. They're definitely an unsung team, but throughout the pandemic, they moved forward with a number of key safety initiatives, increasing the number of monitored beds monitored, as well as assisting with the new task of monitoring oxygen levels in all of our COVID patients. And they have also put forward a whole series of Good Catch Awards. They've also decreased the time, despite the fact that they've had a lot more work to do, they've managed to actually decrease the amount of time between rhythm change and notification substantially. So their whole work process has dramatically improved. And if we could now go forward to their photo, and hopefully there to receive recognition is their manager, Deborah Tran.
Deborah, who do you have with you today?
This is Miss Lashika Winfrey. She is by far my A-star #1 team member. She does the training of all the new staff. She's been here just about 5 years. Yep, and I'm just about to give her a 5-year award.
Oh, great.
And yeah, she's amazing. And she's getting inspired to go to nursing school, so I'm hoping to mentor her
Oh,
into that.
that's great. Good. Thank you. Thank you both for all you do. Couldn't do it without you. Thank you so much.
So do you get to keep the award for a month and then you have to bring it back? Or do we just keep it here?
Yes, the award is current, so it will go to the unit and they will get the display as well as a large banner that goes.
Oh, okay,
All
all
right.
right, thank you.
good.
Congratulations.
Congratulations to all the winners for a job well done. Okay. Next item is the approval of minutes from September 2nd, 2021.
Move approval of the minutes.
Move approval. Is there a second? Second. All in favor?
Aye.
Any opposed? Motion passes unanimous. Next item will be the approval of Tarrant County Hospital District policies and/or plans, and there are 3 of them.
Good afternoon, members of the board. So I'm here today to present 3 policies. They are just annual, triennial policies, and there are no major changes in all 3 of these policies. And requesting if anyone has any questions about any of the policies, and also requesting approval.
So I've been told we can't approve all 3 of them together unless anybody has any questions about them. These are all basically renewals of policies. Anybody have any questions or discussion? No? I would entertain a motion then to approve all 3 policies. Do we need to read them out for the minutes?
As presented.
Okay, as presented.
Second.
Motion and second. All in favor?
Aye.
Aye. Any opposed? Passes unanimous.
Thank you, everybody.
Thank you. So next item, consider performance improvement reports and updates. These are not requiring committee actions. Dr. Stevenson, I think you're up again.
I think so. I think I have the rest of it. First off, I want to apologize to all of you for not being there in person. I have managed to make it through 2 years of a pandemic without getting COVID. And last Thursday, I tested positive. So I have one more day where I have to be here, and I can be back at work tomorrow, but I'm still supposed to be away today, and then tomorrow I can be back in person with a mask on, and so I tend to do that. But anyway, finally caught up with me after all this time. If we could go forward to the patient experience slides, please. And then we'll go to the slide with the graphic information.
It's up, Rob.
Gotcha, Dr. Stevenson.
Are we there? Perfect, great. So this is a summary of our patient experience results this year with respect to our organizational goal targets. So as you can see right now, we are performing ahead of stretch as a whole organization. And as you can see, almost all of our areas are showing good improvement. There's one exception, which is our emergency department. This has become the area of pretty significant focus for the patient experience team and the emergency department leadership. They're working through performance excellence curriculum, so that's the Steve Beeson program, and they have a variety of things in there about how to improve patient experience in the emergency department and working on that. And so that is sort of the thrust of where the effort is at this point, but clearly this is an area of major focus, and we certainly will hope to see improvement in that area in coming months. Any questions at all about that work? Okay, we can go on to the next slide, please. And then on to the next slide. So now we're on to PSI 90 and our quality scorecard.
Yep, go ahead.
Okay, so as far as our quality scorecard, we continue to have issues that are being seen quite a bit around the country, particularly in terms of pressure injuries. Obviously, this is an area of major focus, as is now also an increase in the rates of DVT and PE postoperatively. This area is one that really sort of came out of nowhere. We had been doing very, very well in this area for really 2.5 to 3 years. And then all of a sudden, starting in July of 2021, well, really August, we started seeing a very sudden increase in the rates of postoperative DVT and PE. Now, there's the possibility, although I haven't found any data to speak to it yet, that endothelial damage associated with COVID-19 may contribute to this in some way, perhaps in a long-term fashion. I haven't seen any data to support that fact, although other hospitals are seeing similar things right now. But I will say that one of the things that we've seen is that many of our physicians, especially residents, have started ordering studies to look for DVT and PE outside of standard recommendations. And a lot of this has to do with the workup of fever in patients who have had surgery. There really isn't any relationship between fever and the incidence of DVT and PE, so we are working on proper education for our residents and other providers to make sure that we're ordering within parameters, and we'll have to see if this comes down over time. We did see a few other minor gaps as well around some communication between our hospitalist physicians and some of our surgeons. There was a misunderstanding about what, for example, between our hospitalists and our podiatrists about whether or not the podiatrists wanted to have DVT prophylaxis held right in advance of going to the OR. Some of these patients go back and forth the operating room quite a bit. So there were a lot of disruptions in the DVT prophylaxis for some of the patients. And so we've worked through that, and now they're all on the same page and they don't want it stopped. So we've taken care of that one. But I think that's more around the margins. I think that the bigger thing is to deal with improper ordering and the resultant overdiagnosis and overtreatment, which obviously has downsides for our patients. So those are really two huge areas of thrust right now for our organization in terms of PSI 90. Any questions at all? Okay, move on to the next slide, and I think we can go straight on to the slide after that. Okay, are we there for the infection prevention now?
Yes.
Okay, perfect. So overall, the two big areas of challenge for us in infection prevention remains CLABSI, especially number 1, and CAUTI number 2. CLABSI is getting a huge amount of attention right now. We have a new insertion bundle for the ICU, including a checklist that they're going to have to work through that has been rolled out. It's going to be actually included in the kits and posted during insertion procedures in the ICU. We're in the process of rolling out a new, it's already been trialed in a couple of locations, but it's continuing to be rolled out to some other locations, a solution for scrubbing the hub called Prevantix, which requires a much shorter scrub and dry time, which should help our nurses care for these lines better. We're also rolling out education to our nurses and providers about, number 1, not drawing blood cultures through lines, which has the potential for finding contaminants in the line rather than true infections, and also the need to if you can't get the culture from anywhere else, changing the catheter hub before you change them out. So we've got a whole bunch of stuff going on in terms of CLABSI prevention, so hopefully we'll see some improvement there. And in terms of CAUTI, we're actually taking, again, an ordering stewardship approach in part, where, again, we are encouraging our providers not to order indiscriminate urine cultures. Turns out that there's an entity called asymptomatic bacteria. In other words, just having bacteria in the urine is not enough for there to be an infection. It's really the association between appropriate symptoms and the presence of bacteria. And asymptomatic bacteria can be, depending on the clinical scenario, can be present as many as 5 to 100% of patients in certain clinical scenarios. So, for example, patients who have long-term indwelling folies, if they've had it for more than 30 days, they're going to have urine colonized with bacteria, but that doesn't necessarily mean they have an infection. So we're trying to get the ordering right through education and then monitoring of folks' practices. So those are really the big pushes there. In terms of surgical site infections, things are going fairly well. C. diff's going fairly well. We're keeping our eye on the MRSA number. We've been incredibly low in MRSA bacteremia for a number of years, and we've had 3 this year. So, I'm not sure that's a pattern yet, but we are deep diving it and looking at it, and we will continue to monitor and let you all know what we see as this continues onward. We do have some concerns about peripheral line maintenance, and so that's probably our hypothesis at this point in time. So we will keep an eye on that and let you know what we see going forward. Any questions about the infection prevention data? Okay, next slide. The next slide. We should be down to hand hygiene.
You are.
Okay, if we go forward to the next slide with the data graphic. So every year, Leapfrog requires that we bring forward to you as our board the results of our hand hygiene monitoring program. So this represents the last 4 years, which is really, I'd say, the 4 most robust years of monitoring in terms of the number of observations. During the last year, we implemented a real-time tool, which, as you can see, substantially increased the number of observations made. That's the small number at the top. Our hand hygiene compliance reported is in excess of 90%. And we've been up there for a number of years. I will say that these observations are made manually, so individuals making observations, and there are a number of pitfalls to doing that, including the Hawthorne effect. So if you know you're being watched, you're more likely to perform properly. It's also easier to capture positive data rather than negative data, so it's harder to miss. It's harder to catch when somebody misses their opportunity for hand hygiene than it is to notice somebody actually using the dispenser. So we believe that this is probably an overestimate of the actual compliance, and we're looking at opportunities for getting better data in this regard. We'll keep you posted on that. Any questions about this report?
I have a question. Is this all throughout the district, or is this just hospital?
No, this is everywhere, actually.
Okay.
This is cumulative, whole organization.
All right.
Inpatient, community health, and behavioral health are all in this,
All right, thank you.
of course.
Any other questions?
Any?
Nope.
Okay, next
All right.
slide and next slide. And then one more. It's also a leapfrog requirement that we bring forward to you our the results of our culture of safety survey. We actually did this way back last summer, but we haven't had a meeting in a long time, so it's only coming forward to you now. This result is actually slightly better. So this is the Ahrq culture of safety survey. It's actually a 58-question survey that assesses all aspects of the culture of our safety at JPS. This is the overall result, which is actually slightly better than it was when we last did it in 2020. Or sorry, 2019, I should say. Probably the biggest area of growth for us is actually that folks are feeling less reticent about bringing forward safety issues. I think a lot of that has to do with our very robust Good Catch program, as well as our things like the Golden Mitt program. And so people are seeing that bringing these things forward is important and is recognized in a positive way. So I think that's been positive. We still do hear in the comments that there still remains some reticence about this. So I don't think that's a fixed done type situation, but rather something that we need to keep working on and keep focus and energy on going forward. But we are at least moving in the right direction, which is actually a little unusual for the country because during the pandemic, the majority of institutions have actually gone the opposite direction. So we're somewhat pleased by this, but clearly with really only 4 out of 5 in safety culture, we still have room for improvement, no doubt.
How many?
Any comments or questions about that?
Yeah, I have a question. Who all participate in this study, and what was your sample size?
Yeah, so actually we sampled about, so our sample size was the entire, ultimately could have been our entire employee workforce at JPS. We had a 42% response rate, so it was actually a pretty good response rate for a lengthy survey. We're looking at opportunities to actually harmonize this potentially with the employee engagement survey with a shorter tool, but that's still in the discussion phase. But nonetheless, 42% is definitely considered to be a valid survey. But I would prefer to see a sample size much closer to our entire employee base.
All right, thank you.
This is district-wide too, is that right?
Yes.
Any other questions? Well, I think that's the last one. Thank you, Dr. Stevenson.
My pleasure.
All right. Next item, I believe we reconvene in executive session. Ready? Okay. Reconvening in open session for any other business. Does anybody have anything else? Discussion? No? If not, then I would entertain a motion to adjourn. Second. Okay. All in favor? Say aye.
Aye.
Any opposed? We are adjourned.
The Medical Horizons Committee will begin its inaugural meeting. Welcome, everybody. We'll call to order. Any citizens wishing to address the committee today?
No citizens, sir.
Thank you. Ooh, sir. Oh, wow, I like that. Don't get used to it, right? All right, so let's dive right in. I don't think we have any required actions today, correct? We're just going to receive a briefing from Dr. Elliott on graduate medical education, medical research, and publication reports and updates requiring no committee action. The floor is yours.
Thank you so much, Mr. Montgomery, and thank you everyone for this opportunity for us to be here and just have this committee to be able to give an overview of what we're doing in terms of education here at JPS Health Network, which is such a priority for many of us here. I will say this, it's important to all of us, and every time we have residents and fellows and students coming through anywhere, I always tell people thank everyone for being teachers, because every single one of our team members are teachers, because we're really truly inspiring the future generation of learners and clinicians and all of our interprofessional teams. So thank you for this opportunity, first and foremost. So we're just going to start with just an overview, just to kind of get a general sense, of course open to questions and any thoughts as this committee kind of continues to see what are the things we'd like to bring forward. And we'll go ahead and just kind of start with where we are and what we do in academic and research affairs. So I'd like to kind of talk about the continuum of education. And so the continuum of medical education, where we're looking not only at our student experiences, so we have the undergraduate medical education, but within that we also oversee all of our clinical experiences there too. So that interprofessional team, all of those students that come through all of those disciplines, we also have that oversight too, where we really look at how we can have that pipeline of students coming in and really having that oversight there. Then, of course, thinking about graduate medical education, that's where you think about our residents and our fellows and having that kind of postgraduate experience that they come through. And so we'll talk a little bit about what we do there in that space. And then, of course, continuing medical education, because we are all required to be lifelong learners and providing that experience for all of our clinicians across the board. And so we make sure that we provide that very thoughtfully evidence-based practice to be able to impact practice and future learning. And then underlying all of that, to support that, we have our medical library services that we are very, very excited to be able to partner with Health Science Center on that. And it's been a very robust experience, and I will say it's a highly valued area from all of our folks across the network, everyone, including all of our staff. And then, of course, research. We can't do this without research, because we've got to make sure we're driving processes, we're improving, we're doing all the things around that. And then you've heard this a lot, because it's so important, especially in these last couple years with the pandemic. It's become even more important in terms of addressing our well-being of our full interprofessional team. And so that has not only been a core piece that we're required to address from our accreditation and our medical education standpoint, but it's important across all of our network and all of our team members to address our well-being. So that's kind of where we're going to kind of start and kind of look at that, where we are, and bring this forward to the committee each time. I do want to say we can't do this alone. I can't do this alone. I've got to thank all the folks that help us to do this, from our program directors, our program coordinators, our faculty. We've got 2 program directors sitting right here. And it's great to be able to have that partnership and then to work with our faculty, our students, our residents, all of our interprofessional team members. And of course, I have to thank my academic and research affairs team for helping us to do this work. So thank you. All right, so let's talk a little bit about who our educational programs are. So the graduate medical education specifically. And so we have about 214 residents that are JPS sponsored. We sponsor around 11 programs, about to hopefully be 12. And you see them listed there, from emergency medicine, family medicine, geri, hospice and palliative medicine, now OBGYN, oral maxillofacial surgery, orthopedics, podiatry, psychiatry. We're looking forward to learning more about our child and adolescent psychiatry here momentarily, and then sports medicine and transitional year. We also have partners that we partner with across the DFW Metroplex and even beyond now, as you've probably seen here, in terms of general surgery, ophthalmology, oral maxillofacial surgery, urology, and then other areas of family medicine, internal medicine, and GI. And we thank our partners there. We've also added some of our armed forces folks have approached us there. We've got 200 plus TCOM students come through, and then about 200 other medical students that come through for electives over the year too. And then nursing is so strong. Our partners in nursing are so critical. Probably our three biggest partners are TCU, UTA, and Tarrant County College, but we also work with Southwestern Adventist University, Weatherford College, all these areas too, to make sure that we have these folks come through. So about 1,000 nursing students come through over a year with us. So we're looking for that pipeline, and we need to have that pipeline. And then pharmacy, we have about 90 students annually come through, and those are our Texas Tech partnerships, Health Science Center partnerships, and UT Austin also. And then, of course, with all the other allied health, everything else that we do, we have about 800 to 900 students come through annually. So we're over 2,500 students, like we're doing a lot of work, and so people recognize our experience and what we bring to the table as JPS. And we're continually looking at our capacity and looking at that, and of course it involves us making sure we have folks to teach and that we have the space and the capacity to do that. So that's an ongoing process that the team continually does. So I'll pause right there if there are any questions on this slide.
Questions for Dr. Elliott?
Oral maxillofacial surgery. No problem. All right. So I'll talk a little bit about where we're going to kind of go from here and what we've been doing. So we want to thank our Office of Strategy. Yeah, they've been amazing, and we were, of course, part of that process as we think about, with you as the board, approving our strategic plan. And we love that one of our enablers there that we really think about is being the best place to work, learn, and practice medicine. And under that, we know there's key components there throughout about where medical education and clinical education as a whole fits within that model. So we as a division in academic and research affairs really build our priorities very much aligned with everything in the strategic plan. We've actually created a very robust dashboard with tactics and objectives that all align with our strategic plan to make sure we're driving everything forward. So we look at that. We actually just met with my team just last week we meet quarterly to make sure we know where we are in status reports of that dashboard and that alignment to make sure we're moving these forward. And these are the 5 areas that we've really identified to align with the strategic priorities there. So academic excellence, clinical excellence, workforce recruitment and retention, research and innovation, and professional and leadership development. And what we're going to focus on just for this meeting this time is to focus on the first 3 areas. So we're going to focus a bit on academic excellence, clinical excellence, and workforce recruitment and retention. And hopefully I'm going to provide you a bit of updates of what we've been able to accomplish thus far, and then what are some things that we're looking forward to continuing to work on. And love any input that you have there too. Any questions on this before I move us to a little bit more detail? Okay, thank you. So let's talk a little bit about academic excellence. Well, the way that we define this is really looking at how do we develop this kind of respectful, supportive environment for medical education and clinical education as a whole for the delivery of the highest quality patient care, because we want to also make sure we're personally and professionally developing our learners, and really that's how we're defining that. So a few things that we've done completed to date. All of our GME programs, I'm proud to announce, have continued accreditation, and many of them have actually received commendation from ACGME, which is our accrediting body. So that's just kudos. Even the institution, we just got our accreditation status, and we received commendation as an institution too. So I think that's probably our 5th year in a row to do that. So we're very proud to be able to do that. And then ACGME has been updating their requirements quite a bit, and they're actually doing some more updates too for their common requirements and institutional requirements. So we went through a very rigorous process to update all of our GME policies and procedures, and the board was great in terms, and thank you legal for all the help with that, because we really wanted to do, and compliance, to do this work, because it was really very necessary to make sure we're fulfilling all of those areas. So we did accomplish that, and we're looking forward to keeping that up to date. And then relationships matter, right? And so we have been very thoughtful and directive about all of our relationships with our academic partners, as I've described. And so we want to continue to build those robust relationships and collaborations with our local schools. I mentioned to you a few of those, not only our medical schools, but all of our nursing, pharmacy, allied health schools, everything else that we're doing there. So we've really maintained those relationships. I have monthly meetings with leadership at many of the schools and bring forth all of the things that we have there and looking for those opportunities for us as an organization too in those conversations. And then we've also, as I mentioned, some of the capacity assessments that we've been doing, kind of walking the halls and having conversations with our physicians and our nurses and everyone across the board to see how many learners can we take. Also working with HR because we want to try to look at ways to build that pipeline even more and get to them even earlier in their educational process so they can be a future pipeline for us as a workforce too, and we'll talk a little bit about that. And then what we've done also is that we've started some interprofessional continuing education workshops. This is happening across the board. Teaming is a big part of what we're required to do and need to do, and so the fact that our continuing education continues to pivot to be virtual for the last couple years, but it's now even more interprofessional, and we're really excited to see that. And then well-being, I told you, we've really had to be a little bit more comprehensive, directive, develop new strategies around well-being, and I'll talk a little bit more about that in the next slide too about that, but we've been able to really do well in some well-being areas too and monitoring that closely. Other things that we're looking forward to building upon that we have some actions in progress is actually a pipeline program. We've been in conversation with Fort Worth ISD. We want to pilot a pipeline program. We've talked about this, I know, within the board of managers of looking how we can get the younger students. Pipeline has to start earlier. So we're looking at some ways that we're going to actually launch with our partners with Fort Worth ISD for junior and senior high school students from different schools. We're looking at some schools locally here, O.D. Wyatt, Trimble Tech, a couple other schools too, that we're going to actually start with a big field day celebration in April, where we're going to welcome them. They're going to actually get to meet nursing leaders, other leaders, physician leaders, all our clinical leaders, and just be able to hear about what it's like to be here at JPS and work in the healthcare field. So we're kind of excited about that, to kind of launch it, to give them that kind of field day, and excited about that. And then beginning in the fall, where we'll have that longitudinal program for those that are in these science, technology, engineering, mathematics program to experience that practical piece, and their practicum pieces here with us at JPS. So it's a journey, but we got to start somewhere, and so I'm excited to start there and see them come through. I thank everyone for the efforts too that we've been doing on that. So the team has been great, and I want to thank them for helping us with that. Excellent. And so more to come. I'll give you more updates as that evolves, right?
What high schools were those, Kim?
So we have got O.D. Wyatt, and I'm just going to have my Trimble Tech.
I graduated from O.D.
All
Wyatt.
right. That's awesome. That's awesome. And we have a couple other schools too. Well, you might have to be one of our ambassadors there. You'll have to see. So. And then we're going to have experiences in like medical billing and coding, EKG, phlebotomy, patient care tech, pharmacy tech. So we're excited about our partners across the network. They're just excited to do this too. So we got to start early. We got to get them early. All right. Any questions on that? All right, we're also exploring other opportunities for some simulation. And so we realized that to get better, one of the parts of clinical education is ensuring that we're doing continual simulation education, so in an interprofessional way. We do that a little bit currently. I will say like OB does that, and ED, EM does that in different ways, and family medicine too, and we want to do more of that, right? We want to be able to come together, and so we're exploring some opportunities how to expand our interprofessional simulation education to be even better with the quality of care that we provide. And then we're also working with IT. Thank you, IT, for working with us on these virtual educational platforms. As you know, we had to shift to virtual for many things, and so that's also for our learning opportunities too. And so Family Medicine has been piloting some of that too, and some platforms that we're looking at, but we're continually looking at ways we can make that even more robust. I know Psychiatry too has been looking at some things there too. All right. Any questions on just some of these areas we're working on? All right. So let's talk a little bit about clinical excellence, our second priority area that we align with our strategic plan with. So this is about promoting a clinical and learning environment that is recognized for its excellence in patient care. Our patient, of course, is our true north, with a focus on the Quadruple Aim and fostering a culture of safety. So you've heard, of course, as we work very closely with our quality and patient safety team. The Quadruple Aim, I like to describe it as the 4 areas that we say. It's in terms of what we always do, what we strive to do, providing better health, helping us to get a better healthy population is what we're here for, providing better care at a lower cost, and of course making sure our clinicians are satisfied in the work that they're doing and their well-being is being taken care of. So that's kind of the 4 areas of the Quadruple Aim. And so some of the things that we have completed to date, so ACGME, our accrediting body, has what's called the Clinical Learning Environment Review. And they do this every couple years, but we've been out of the window now going on 4 years with COVID, and so they can show up any day now. So we try to do the same thing we do for Joint Commission, to be continually ready. And so we've created a continual readiness dashboard. We have a project manager that we've identified to really help us drive this, because there are 6 key areas that we have to focus on, that when they come, they'll talk to the C-suite and all of us, and they'll do the walk-arounds. They'll spend a couple days with us. They only give us 2 weeks notice, and they will just focus on the 6 areas. So they'll focus on patient safety, healthcare quality, teaming, supervision, well-being, and professionalism. And then within healthcare quality, they also focus on what we're doing in the areas of health equity and healthcare disparities too. So that's why we want to stay continually ready for that. So that's something we're driving forward. Also, part of the clinical learning environment review, but also part of just doing best practices, is making sure that our residents and fellows are part of our health network committees. So residents are assigned because we want to build these leaders to do this and to do this work. So we've got residents who are part of our committees. And then we've also worked very closely with nursing. We thank nursing for all the work around the resident supervision requirements too, and making sure that those are readily available. They actually just did that again with Joint Commission, and CLEAR also requires us to do that. So that's where we keep those things up to date. We keep that on the intranet, very accessible, so our nursing can identify what the supervision requirements are for each resident. And then we have the Caring for the Caregiver team, and that's been a partnership, I think, Laura and her team, for Laura Burnside and her team for the work we've done, and also Zelia Baugh, and for the Caring for the Caregiver team. This was really established quite a couple years ago, but we've really had to do a lot more with that. And that's also one of my team members, Dr. Glenda Mutinda, is part of those, that Caring for the Caregiver team. And so those well-being initiatives have been really important, from Schwartz rounds to healing conversations to everything else that we're driving forth. And that's been so important. And one of the newest things that we developed was something called Stronger Together. It is a peer support program that when you've had adverse or challenging circumstances happen on your team or for yourself, that you can actually reach out to somebody who is well trained as a peer to help support you through that. So it could have been any kind of adverse outcome or a challenging situation, and they can connect you to whatever resources, have that sounding board, or be able to connect you to EAP or other things. And so what we do is a train the trainer model too. So we've got 9 trainers now across the network. And we actually have about almost 50 peer supporters across the whole network in different departments now, which is fantastic. And we're growing that, and that's one of our goals, to grow that so that every department will have peer supporters. So you know at any time of day, you've got someone there that you can reach out to be able to do this. And it was formerly called the Second Victims Program, knowing that there's always, when bad things happen or challenging things happen, that we have to recognize that our team members are also feeling that too. And so we want to be there to support them. So that's been something very positive we've been proud to be able to launch. And I thank Dr. Mutinda for her leadership on that. And then about 4.5 years ago, we started the partnership with Employee Assistance Program for the well-being check-ins for our residents. So residents in their first and second year are required to check in with EAP. And that came out of a conversation, I think within my first month of getting here, a little over 5 years ago, when a resident came to me who was graduating and said, "Hey, I was a near miss." And I really think that we need to be a little bit more proactive of getting our residents to kind of just do it like you would check in with the dentist, check in with your own well-being, and have that. So we thank EAP. It's been a wonderful partnership. Of course, when COVID happened, we had to figure out another way to do this, and we shifted to a virtual platform to be able to do that, something called Smart Counseling. So now the residents can actually do texting, video, audio type of check-ins now, and that's been working well. And then, of course, we have to make sure that we're doing quality improvement in patient safety, and so having curricula across all programs is important. And then we've also implemented the Institute for Healthcare Improvement curriculum and that certification for all of our residents and fellows. So they all graduate with that certification there. And then some of the things that we're still actively working on is working with our quality and patient safety team on all things ACGME Clear that I mentioned to you about. And so we're going to be doing things like mock RCAs, we're trying to get certain reports done, all these things, patient experience, all those things that we want to make sure happens and our residents have. And then we've been doing longitudinal faculty development sessions. We've held some sessions even this year for our faculty and our GME leadership, things on recruitment and retention, diversity, equity, and inclusion. We've done some things around research, well-being, research coming up, well-being done also. So we always want to make sure we're helping our leadership also stay abreast of those things. And then regular reporting, we're working with our patient experience team because we know our residents need to make sure they get their data too, and so we're working on ways to get that regular reporting of patient experience data to our residents, and we know that's aligning with our Compass Scorecard and our strategic initiatives. So all of those things that we're doing right now too is to align with our strategic initiative and our Compass card. So even the quality and patient safety, the GMEC just approved too that we're going to be working each program to align some of their projects in their programs and in their departments with those Compass scorecards areas. So we're going to start that process too. All right, any questions on this? All right, I'll spend the bulk a little bit on this area. So the third area that we are focusing on is definitely workforce recruitment and retention. And this is partnership in every single way. So this is about recruiting and retaining a diverse and inclusive workforce of residents, fellows, faculty members, and staff in accordance to our mission and aligned with the needs of the community we serve. And so we have been working very diligently on that, and I want to thank several folks just across the board, our physician groups, working with communications, IT, legal, everyone to be able to do this work. So a couple of things we had to kind of do. So part of this is where we had to increase our visibility. So you probably recall a couple of years ago that we did have to go virtual. With the pandemic, to be able to recruit, we normally would have them come here, do the interviews, do everything, but actually nationally a decision was made that all of our recruitment efforts for our residents and fellows would occur virtually. To do that was a kind of a big lift. We had to make sure that we had a presence out there and great visibility, not just from reputation, which is great for us, but to make sure that we had electronic media that was reflecting that. So if you haven't had a chance to take a look at our website, please do. It is great. They've got great videos there too, and social media presence also. You can follow our programs. And it's just a really great thing to see us out there. And we've already had students who have applied comment on our website and our social media and follow that. So that was important to have that occur. And then we also are really working hard to now, we had to pause a second there the last 2 years. We were just kind of gung-ho to get out there and do some recruitment efforts directly with some of our schools key medical schools, especially those that are minority serving institutions or historically black colleges and universities or Hispanic serving institutions. And we had already identified them, but we had to put a pause on that because there was no activities happening. But they're back, and we are actually looking forward to beginning this coming month, next month, that we're going to be doing some of these key efforts of recruitments there. So we have some visits, some recruitment fairs we're going to participate in to really see if we can advance the diversity around our race, ethnicity, gender, all of it across the board to help us with that. I want to say huge kudos to my team who have created another incredible dashboard of these particular areas in schools. So identified by the Association of American Medical Colleges, AAMC, also U.S. News and World Report, all of those key schools that are doing really well in these diversity, equity areas, we've identified them, their contact list, how we're going to go about remaining really closely contacted with them. So that was something that we are excited to keep moving that forward and start that process again. And then we always look at our data annually to make sure that we've got what are our trends, what are those demographics looking like, what are those opportunities to evaluate that even further. And then we really wanted to make sure we had some formal educational activities. But we started with an implicit bias training and just one on general kind of DEI, recruitment, holistic evaluations of our students and our applicants and things like that. And so that's where we actually had a kickoff in September with some special guests, virtually, special guests, and a partnership also with TCU School of Medicine to bring that forward. And so we had all of our program directors there, our faculty there, and residents there too to do that training there. And then we are now going to be we just launching a DEI, a Diversity, Equity, Inclusion Graduate Medical Education Committee subcommittee. We have a few subcommittees from our GMEC that drive some of our processes, and so we really believe in this work and that we need some drivers with that. And so we're going to be looking at a DEI subcommittee that's going to be looking at not only the building that cultural humility, but looking at our work and our efforts across DEI and workforce recruitment and retention and education that we need to be able to provide across the board. And Dr. Ahrq actually will be chairing that committee, which we're grateful for as Program Director of Psychiatry. So more to come on that. That's just still very early. We're recruiting for members of that right now. And then ACGME, we got accreditation for our Hospice and Palliative Medicine Fellowship. We actually are matched into that already, and that's really great. So we're excited to welcome that fellow coming up in July. That's a great way to actually partner very closely with our geriatrics, because we understand the challenges around geriatrics, but our population needs it. And we're finding that our learners nowadays, they want that combined experience. And so that will help us also recruit even more folks into our geriatrics, hospice, palliative medicine experience. And then we also have an application, as I mentioned to you, pending for Child and Adolescent Psychiatry Fellowship. This is going to be critical. We actually already received funding for this, and this was something we needed to be able to kind of move forward. And unfortunately, we sometimes lose a couple residents in their latter 2 years, because they want to go off somewhere to fellowship. And so we know if we can keep them here, just a couple, just two, it's just 2 for 2. But it's important to keep them here, and we know behavioral health is so critical. And we've also been having those conversations with our physician groups to know that this is so important. And then we developed a street medicine elective, so that will also, I think, attract our students to us too, to do this work that we're doing here too, so thank you for that. And then we're always looking to find money and to expand and to grow, and we're going to continue to grow. And so we were pleased to announce that we also were just awarded, and we still have one more award to hear about, but we were awarded our expansion grants and had actually even more dollars. We had about $1 million+ more than we've had before for the biennium, and we were awarded $2.55 million just recently from the state. So that's a win.
Put a smile on the chairman of the finance committee's face.
Yes.
Tricia, before you go on the street medicine piece, that's what we're doing with the homeless
Yes, sir.
work group. That's awesome.
Yeah,
that's
it
a great
is,
program.
So excited and appreciative of our team members over there at Healing Wings and Joel Hunt and everyone there, and in family medicine, they're doing this work. So it's something we realize is very attractive. And also our emergency medicine group also has now joined into that. So now it's actually a true interprofessional where we have EM and FM, emergency medicine and family medicine, coming together to do this work.
Awesome.
Yeah.
Could I ask a question on your Gme Expansion?
Yes.
What service is it? Is it just psych or?
Yeah, the ones that we got awarded for specifically for this is for psychiatry and for family medicine. We're still awaiting our emergency medicine from the ETEP program to hear from that, but those are the main ones that we've gotten to do, to be able to do. And that supports us to be able to continue those slots that we have to be able to do that work.
Okay.
Dr. Elliott, it's great work and really impressive, the performance I've seen happen over the years, especially under your leadership. Thank you.
Thank you.
Tell us a little bit, just to kind of give us an overview of the Gme funding. Okay, so
Yeah.
Gme comes in several different ways, right? And so the state has a higher coordinating board that sort of directs that, but tell us about how the federal funding is.
Absolutely, absolutely. So there's multiple sources too, and we can probably put that in a future one. I'm happy to bring that forward. So overall, for graduate medical education funding, there are multiple different sources that we look at, and we work very closely with our finance department to make sure that we're auditing and we're checking those regularly. And so there's federal funding that happens. That's from CMS. So those Medicare funding is one of the primary sources that we have. And so back in 1997, they set a cap for us, and so we're basically where we have a cap of a number of slots that they basically provide for us. We're about 114.9 slots. And they pay us based on that, and they pay what's called a PRA, also per resident amount for those particular slots. So there's Medicare funding that we do get for that, which is very good to support salaries. And that's broken down, I won't get into too detail, but that's broken down into what's called direct graduate medical education funding, which directly supports a lot of the areas around salaries and other things. And then there's indirect medical education, which is a whole formula based on our beds, our DRGs, all of those different things too that they also pay out for us. So that's the federal side of things. And then on the state side, there's multiple different opportunities there. So the Texas Higher Education Coordinating Board is the organization that the legislature actually designates to be able to dispense these funds or disperse these funds. And so every 2 years, the legislature meets and basically decides how they're going to move forward in terms of graduate medical education. They fund different areas, from directly funding some areas of family medicine, directly doing some formula funding that goes directly to medical schools. And so that's where also a few years ago where we also get our pass-through funds through Health Science Center, and that's also one way of that formula funding coming to us, and we have those agreements there to make sure we get those funding based on the number of residents that we have that we report out every 2 years. And then there's also other funding, Gme Expansion funds dollars, which I just mentioned. So there's multiple different funding on the state side. And then, of course, there's also what we fund as an organization through our revenue and through our other sources, too, to be able to support that. So there's multiple different things that we have to look at and ways to fund that. Happy to, hopefully that kind of answers a little bit about that.
And it's great that we get the grants, too.
Yeah. And we're always looking for opportunities and working with finance to do that, so.
Dr. you mentioned on the federal side, how many residents does that support?
So on the federal side, there's a cap, and that doesn't necessarily include our podiatry and dental, because we do get some funds for that too. But the last slide, if I remember looking at, we do a report and audit every year that we have to send out. It's about almost 114.9 or so.
Okay.
Yeah.
All right, good. Thank you.
Yeah. Okay. All right. So what are we working on? Well, we're going to have to keep this work going, and we want to make sure we are increasing the diversity of our workforce, and we're also looking at ways to work together to make sure that we are retaining our residents too. So those are probably the two things that I think are really important. And in doing that, to be able to increase our diversity and to increase our retention too, is we got to increase our candidate pool. And so that's why I mentioned to you some of the things we're doing in terms of participating in some of these national residency recruitment fairs, particularly looking at underrepresented in medicine. When we look at the underrepresented in medicine, the way that that's been defined nationally is looking at our Black, African American, Latinx, Native American, Pacific Islander, Native Hawaiian students, and looking at ways that we can help to recruit and retain. And so that's what defined as underrepresented in medicine. And so we're looking at that, so we're trying to increase the number of residents, students that apply to us. So that's something we're going to be tracking, we're continually tracking. So the more we get visibility out there in these fairs, we're hoping to see more folks apply to our programs and hopefully and eventually match to our programs down the line. But it's a journey, because I'll tell you, nationally, the statistics, the pool is small. The pool is small. But we had the very first year nationally that the pool went up in underrepresented in medicine in about 40 years. Yeah, and so they actually normally would be around kind of 7% African American and 6% Latinx, and just about kind of 13%. And then this went up this year to 10% in our African American, Black and African American matriculant pool. And then we went up to about 9% in our Latinx population too, in our national pool. So our national pool of underrepresented medicine matriculants, not graduates yet though, but matriculants, went up to about 19%. So we went from 13%, which we've been flat for so many years, to about 19%. So we got to try to figure out how we kind of continually capture, and that's why we've created those dashboards and are going to be having those activities kind of moving forward and just continually tracking. So.
What is the goal? What percentage are we trying to shoot for?
Well, that's something we haven't necessarily defined. And I think that's something that's a little bit of a challenge, because when you look at, we can say, well, we have our population, but that's also when you don't have a pool that reflects that population, that's also very hard, right? And we've kind of looked at saying, making sure we are at least not lagging behind national matriculant data. So we've kind of been going steadily upwards, about 11, 12, 13% to 15%. Of underrepresented in medicine in our area here. If we look at kind of where we are as a county, Our county, the last demographic data, I think we have African American about 18%, Latinx around 30%. I think whites 45%, and then Asian 6%. I think that's probably a lofty goal to try to look at the matching that. I do think what we have tried to do is to try to increase and steadily every year, which we have. I think definitely the pandemic probably puts a little challenge in that because of just being able to have that visibility and to be able to kind of, for them to see those experiences. Because one of the things we've learned from our underrepresented medicine too is that why we're going to be working we're working very closely with our physician group partners is that they also want to increase, we have to improve the faculty demographics too, and our med staff demographics. And so, which are not bad, they're about 10% in those two areas, but we need to continually improve in that.
Have we tracked the percentage of the diversity group that rotate through here in, when a students and then against what we recruit them?
Yeah, we're doing that now. We're doing that now where we're looking at who we've actually, in terms of rotating, or you think in terms of?
Right, because they have to rotate before they can match, right?
So, so the thing about that, that's also one of the strategies you probably see up there where we're trying to look at, is looking at our number of students. You see there, URM students participating in electives and exploring scholarship opportunities. We want to increase that. Here's a challenge a little bit with that. We have certain electives and certain students, but we don't necessarily have the self-identified demographic data of those students. Okay. So the students are a little bit different. So even like in our VSAS, which is for our fourth-year electives, they don't report. There's no reporting of their race or ethnicity at all. And then for us to be able to get the others, for those from our TCU or other students that normally rotate with us, you have to kind of balance those, what's reportable from the schools for us to do that. Now, we get the data for when they apply to us. If they choose to disclose, they'll disclose self-identified data on that.
Have we defined what important to us, meaning, right? If you're taking people from, let's say, a family medicine program, we top 5 in the country. So we know where we can pull the students from, right? And then if we support local, so that they can stay here, work here, and graduate and stay here.
Absolutely.
Then that may eventually bring that ranking down.
Yeah.
Where do we draw the line on that?
Yeah.
To see
those are exact strategies that we're doing, absolutely. I mean, our local students are very important to us, and I think that's why we also very much value that, and we actually make sure that they're part of our process of interviewing, looking to stay here. And I think that's also why our pipeline, looking at having that foundation here locally, is important. So those students that are in college, those students that are in high school, and that they eventually get to medical schools, and that's why still most of our residents are from Texas. So that's why still the majority, greater than 50%, and a lot of them are, and even more so trying to look at those that are local, like you said, too. So that is something we're definitely looking at and continually growing in that area, for sure.
Have we done the survey with the students that rotate through here for clinical rotation to see what's important to them? Because I kind of look at it from a unscientific way, because I spent some time with the students also as well.
Yeah.
And the number one things that they like to do residence here, and I don't know anything to say it's true or not, but when they residency here, I think we pick up all their insurance or something like that, so for them it's important to them.
Yeah.
But then for the students that rotate through here, it's a lot of expenses for them to get here, find a place to stay. And their number one complaint is that we don't allow them to hang around Doctor's Lounge for free food. So it kind of leave a bad taste in them because other facilities do offer that. So I'm just trying to give you some feedback. It's not much, but it does create a lot of gossiping. Kind of like because they poor, right? They students.
I get it.
It's hard to go through all the rotation that they want to go.
Yeah.
And then they have to find a place to stay, and then still have to pay for food for it.
Yeah.
If we provide that for our physician in the lounge, just let them have it, because it's not like, in addition, some eat, some don't, right?
Yeah. I'll tell you, it's multifactorial. And so, yes, we do get some feedback from our students and our residents alike. And the students, a lot of times the things that are important to the students, when especially they're selecting places, the number one thing that's important to them is location. And that family support and having some support. So that's the number one thing we get. And we do survey, especially even post-match, we get that survey and we look at all of the survey data to try to improve our processes moving forward. As far as to your point with the food and where they are, I will say we've got a wonderful resident and student space that we do. And the students actually co-locate very closely with the residents. Yes, the doctor's lounge for the faculty physicians is a little different, and that was something that's a med staff thing that I don't necessarily go towards that piece, but we also provide, we provide for our students in many ways that they kind of share along there, and the residents will take them along too. So, but we can always look at opportunities to grow. We take that feedback, but overall, I'll say our student feedback has been incredible. Yeah, they really value the experience here and what they're being able to do and care for our patients, and they enjoy our faculty, our residents, and I think we do some perks for them too. And you're right, I think there's some things that attract them coming here from the benefits that we do provide, and which I thank HR for helping us do that. The benefits we provide and the support system that we provide here for them has been a real positive for them.
What type of students were you talking to, if I may, DT?
I'm sorry,
Which students?
some TCOM student here.
Oh, TCOM students.
Yeah, and they actually are right there with our residents in the lounges, so I'm not sure. Maybe we just didn't get a chance to go where they needed to go, but I can follow up offline with you on that
They
if
said
you want.
that they don't get, other hospitals, they get food there, but our hospital, they don't. I don't know anything.
They get a stipend for food from the cafeteria. It may not be a large one, though.
Yeah, I can go back offline. We
they
can
know
look at
they have
that.
stipend?
Yeah,
It's
we
not- I don't
communicate
think
a
they
few
do.
things, but we've had some things where we've had stipends before and some stipends, or we have some snacks and we do different things for them depending if they're on call, when they're on call or when they're here. So I'll look at it and I can circle
That's
back.
We
right. I
may
was
have
gonna
the program, but they may not know that we have that program for them or something.
I think we
because they
do,
don't.
though. I think we provide them food. We do. Yeah.
Star, we have food. They come
Have it in their mouth
They
when I see
do.
them walking around. Between the residents and the students,
They
they're
have
always
food.
eating nonstop, so.
Yeah, they do. We try to take good care of them.
They might not have, I mean, and at times, like myself, other faculty and residents, will obviously this was pre-COVID, go big group lunch for the team and stuff
Right.
like that.
That's students, right, not the residents, right? Residents, I think differently. I'm talking about the students.
Residents get a very generous.
Oh, both residents and students, yeah.
They
get
free
fed.
food on their badges. They can go in the cafeteria.
And
And
students
then
have,
they also have a snack shack. That's their snack shack.
So, yeah, I can circle back off.
We'll follow
for that.
up to
We can
see
follow
whether
up.
we can make it easier from the meal side.
We can follow up. But yes, we do feed our learners and we do try to do our best, and they're invited to all of our activities too that we do. So, and our didactics and other things we do have, we had to pause some of that, things are fluctuate, they fluctuate based on where we are with COVID, but we do our best to make sure they're taken care
I
of.
think that's good feedback, though, and we need to make sure that they feel part of our program partnership, belonging, and we try to do that, make them, with the students perform at the residency level. We make sure that they're just part of the team when we're teaching, but that's excellent feedback. We need to make sure that we do that, too.
Right.
Charlie's feed them, keep them happy, will give me another 100 applicants next year, so.
As you were talking about recruiting, and we always want to be conscious and cognitive of a local school, but if the local school doesn't have a diverse base, then what's our plan? Because if you're talking about some schools that you don't have a lot of diversity there, and so it's going to be hard for you to increase your diversity if your locals don't have. So what is our backup plan?
Yeah.
We have partnered with our local schools also on a lot of the diversity, equity, and inclusion. And several of our faculty, and including, we are also part of that admissions process. And so sometimes we're looking at that and we are working with them to make sure they're also advancing their diversity and that we're working with them on specific DEI activities. And so I will take a note. We've got an activity where I think 3 or 4 of our faculty will be participating in coming up this month where they're doing a black men in white coats activity. And so to get in front of the students. And so we've got 4 of our African-American physician leaders who are going to be participating in that and a fellow also too. So you're right, we've got to also drive what we're doing locally, be a part of that process and conversation. We need to be at the table, and then we also need to cast our net wide. Yeah. So that's, and I will just say, like I said, we were really wanting to launch that off 2 years ago. We were ready to go to these places, and then everything shut down. So this is just restarting it again now, this spring. Yeah. Great questions. And so just to wrap up this slide here, just to say, so one of the things also we hear and we recognize in our retention piece and looking at that is working with our physician group leaders. And I know Dr. Becker and I have had conversations and are continuing conversations, and I just really appreciate his 4-pronged strategy there. And one of those was really creating that community of belonging that he mentioned. And so part of that is going to be looking at how do we also increase the diversity of our faculty. Physicians, and then also looking at some strategies together to retain residents too. So we're going to be working closely on those strategies. I think we're early in those conversations, but also what is it that our community actually needs too, and the type of physicians that we need to make sure we're retaining. So we know primary care is very important. We need to have some doctors in our community clinics too in doing that. So we're working closely with family medicine. We're going to be developing a community health, community medicine residency track and that experience. We really want to have that community immersion experience too. And so that's something with Dr. Casey and Dr. Fowler that we'll be looking at so that, you know, as we look at our future medical homes too, getting those specific docs to be able to be a part of that and to be physician leaders in those medical homes too. So I appreciate that. More to come on that, building that and having a faculty champion really look at that in addition to the other wonderful things that our folks are doing. And then behavioral health, like I mentioned to you, that was really key. And so that's why we've been trying to grow with our behavioral health and look at that. And then, of course, I think also with Dr. Becker, we're talking about some of these procedural and these surgical specialties too. And then we're going to look at some opportunities to grow fellowships. And that might be in partnership with some of our community partners too, but we want to make sure that we are serving our patients and we are building it and we're working collaboratively around that. So it's early in those, but we're going to definitely work towards that. And one of those areas too is also making sure our residents can see themselves here. So getting in front of them early and recruiting very, very thoughtfully and very early so that they see themselves here too. So we're going to be working on some transition to practices and some recruitment specifically of our residents so that we know every department and every program, seeing those residents, they can actually, starting in their first year, start hearing like, I can be a part of a claim, I can be a part of this, I can be this, I can see myself practicing in this group practice in this way too. So we're going to start some processes there. I just wanted to say, just one more thing on this to the point that you mentioned too around just ways that we can incentivize our students, particularly our URM students, is actually we're going to be looking at, once we get our foundation person here, looking at some scholarship opportunities. There are programs across the country now and organizations that are actually having URM scholarships for our students to actually come. So to your point, DT, it's that whole thing where they can come and they're reimbursed for like housing and food and some other things too for that period of time. So we're hoping we can build that and look at some ways to build some scholarship opportunities here aligned with some of the things we see happening across the country. And then, of course, just always working on our strategic priorities. 3.2 is that diversity piece, and so I'm glad to be able to work with our Office of Strategy around that. And one of the other areas that's not on this list here that I just want to mention, too, that I'm going to be working with Legal and Office of Strategy with Lauren Poe and Dr. Duncan on is how do we also maybe explore becoming figuring out what part of our network can qualify for being HPSA
facility again, because that actually brings us National Health Service scholars, that brings us a lot more in terms of nursing scholars, that identifies URM too, and it, we know at the national stats for those that graduate from medical school that identify as underrepresented, they are the ones most likely to go serve our underserved population and serve as we do.
So that's health professional shortage area, right?
Yes, health professional shortage areas.
The loan repayment program.
And loan repayment.
I'm surprised we don't offer here. So,
Yeah.
fine to-
There's also some benefits for loan reimbursement for the participants in those areas, and
There
a
are.
lot of other benefits.
They are, and they also have even a federal faculty reimbursement program if you're identified as such. There are a lot of different things. Like I said, nursing is part of that too. If we have that designation, they can also get reimbursed for their education too. So that's something we'd like to explore again.
Dr. Elliott, can I ask you a question about, and I think it's back, your comment about the quadruple aim is incredibly important, because that's weaved in each of your areas that you're focusing on today. And one of the areas is that one of the quadrants of that is cost of care, right? Not to mention the quality and the patient experience and the clinician experience. But the cost of care is something we don't really teach a lot about. Sometimes we should maybe think about that in terms of the development of the community health residency programs and this whole idea of population health and managed care in the future. It kind of begs the question that we need to rethink how we're, or at least how we're looking at training our physicians of the future in primary care too, right?
Absolutely.
So are we going to be studying outcomes on primary care and looking at that at the same time? And then I guess that also will sort of beg that we need to think about training and management care, risk management, these types of things to try to get upstream of the costs and try to prevent a lot of catastrophic things in the future. And that takes a completely different training, right?
Absolutely,
So-
absolutely. And that would be a part of the curriculum you want to develop. You want to have that population health component to it. You want to be able to have that understanding of leading that. Actually, the ACGME actually just developed a new fellowship called the Health Administration Fellowship, because they recognize that we need residents to be able to do this work and go beyond. And so, yes, absolutely. And I think even in that, what you see there, the Transition to Practice educational series, that would be a component of that too, is to be able to say, what does it take to be able to transition to a practice and understanding the cost of care and those pieces. And we actually have residents who are very, very much wanting to learn more about these pieces, want to know about quality, want to know about cost and working with that. And that's why it's great that they're also part of these committees across the network too, because they're learning some of that as they're listening through that. But to formalize that in a curriculum, and that's is very much something we're wanting to look at too, for sure. Thanks, Dr. Haynes. I'm sorry?
That's more like a hybrid with collaboration with like Baylor or Johns Hopkins or somebody to population health piece of it?
For the fellowship, or just in terms of a curriculum, or?
A curriculum type thing.
Not necessarily. I think we just got to probably see what the best ones are out there and best practices. There are some things already out there that we could look at incorporating. We, of course, would also want to work with our physician group partners to see how they would want us to do that, and maybe utilize some of our own brain trust that's here locally too, to be able to build upon that. There are some formalized programs, but there's actually some great, resident-specific curriculum that's already even out there that we could incorporate too. And I will say the TMA also offers some too. So
because I know the family medicine program at UT Houston is very much focused on population health.
Great.
And some of the students actually taking classes from Johns Hopkins for the MPH program while they're doing it.
Fantastic, yeah. And I think as we grow too, when we look at the community health piece and community medicine, if we do start to incorporate any kind of advanced degree components to that, that would be something we would explore here too. So that's something we're looking at.
Dr. Elliott, as the family practice residents are going through training, they have a group of patients that they follow, right?
Yes.
So as a part of that, they are now going to be looking at their cost of care. I mean, it's hard for me to, it's hard, it's, if you're training doctors to go out and work in the world, then there has to be a piece where as they're training, they learn to look at their cost and how what their utilization is. So that's a part that you are talking about, building into that. Because they already have a practice on patients that they're responsible for. So they don't look at their care that they are given now. No one is telling them how, I mean, of course they order more tests, but we expect that, but we would not expect you to be 100% above the average that's on a, you know, so is that not part of their curriculum now?
So it's not necessarily formalized. Okay. So I will say this, the ACGME Family Medicine, what we call residency committee, they are going through a 10-year complete revision of their requirements that will go into place in July. It's under comment period right now. And so we'll have a new set of requirements come July for family medicine. I will say that there's a community integration component to that and probably more a population health part of that we're going to have to thoughtfully look at. I know Dr. Casey and I will look at it together to see what is it that we need infrastructurally right to be able to meet some of those requirements. I will say there's some limitations because you have to have the reporting structure to do that for all of our, for everyone to be able to do that and see that data.
You'll be right on target. We'll
Yeah.
have all that time.
I think
But
it's
yeah,
to,
we're not-
to Dr. Elliott's point, it's bigger than just the residents. I think
It
we have to
is.
do it for all of our physicians to be able to start collecting that information so they do understand how they compare to others in ordering tests or how they use medications, prescribing. So there's quite a bit of that to do, which is part of the population health. And hopefully with this VP of Managed Care that we're starting to interview, they will be able to help start bringing all of that
I have no
together.
doubt in my mind that will be rolled
We
out.
are. We're going to start bringing that data to you. But we will be able to bring it down to the resident level because it's important that they start early understanding how they look at that.
That would be exciting. Thank you for that, and being a part of that would be great. Any other questions? Just the last slide. This is just to kind of just let you know that we're going to keep us in the forefront with our Compass Scorecard in terms of retention. We worked with our Office of Strategy to kind of define this Compass Scorecard metric for retention. And so how do we track our resident retention following their training years? We went through different ways of looking at this, and we kind of landed here to say, well, let's go ahead and look at the number of JPS residents who are privileged on our medical staff within 5 years of their graduation, so that we're capturing folks when they come back. Because we don't want to just say it's just within the first year of graduation. We know folks come back. And one of the things actually I'm pleased to report is actually 43% of our physicians in the specialties that we train in here are JPS grads.
Yeah, that's great.
So we're doing something right?
No
You know, so they
no
do want to,
question.
and sometimes they leave and they come back. Yeah, and they come back. And so we want to capture that. And so this is where we've kind of landed to say, we'll measure that, and then over the total number of physicians privileged in that academic year to see where we're going. As you see here, you know, we had a COVID effect. And I think that's not unusual. We're hearing a lot of people who are leaving necessarily or making decisions based on family. And a lot of people are deciding they just want to be a little bit closer to family or doing other things that do that. But I think what's going to be important, we're going to slowly see this go up. I think doing the initiatives that we're going to be doing with our physician group partners to be able to get to our residents early, work on retention strategies, recruitment and retention around that, this number will slowly go back up and go even greater than this. So I think this is going to be nice to see this on the scorecard each year.
Yeah.
And that's our last slide.
Mr. Chairman, I just want to say one thing. I guess I've been here 15 years, maybe it's too long, but Dr. Elliott, your leadership's amazing. And I'm going to reiterate what Dr. Haynes said, but you know, you used the word, we're doing something right. I think it's great, this institution. I think we're doing a lot of things right. And I commend you and the entire leadership team for what we're doing. So this is exciting stuff. This is the future.
It is.
It's getting competitive out there for all these students. We want our share of those outstanding students to come here and be here and stay here. And so I commend you and your staff for what you're doing.
100%.
Thank you, Mr. Chairman.
Thank you, Mr. Powell.
So I purposely took the items under 4 in reverse order because I really wanted to get Trish's overview of, and that was perfect, kind of tee up this next subject, which is the context of the purpose of this committee. To back up a little bit, you know, all the things that JPS does in this community and the impact it has, that the education piece is probably what I'm most proud of, and such a huge impact. One of my favorite JPS stories in all the years I've been associated with, I bumped into a guy in Munich, Germany. Yes, Charlie, I was in a bar. But he was a physician, and he had trained here. And we got to talk about Texas, and he goes, I used to live in Texas. And he, many years ago, trained here. I'm like, that's the impact that we've had across the country, across the world, which is just phenomenal. But what I'd like to talk about now is, let's talk about the purpose of the committee, how we as a committee can support what Dr. Elliott and her team are doing. She's obviously going to be feeding us with a lot of information and educating us a lot. But I want us to think about, and I don't think anybody here is shy or dispassionate about, education here and the role that it plays. So I want us all to really be active participants, and how can we push the envelope? Daphne gave me if you look at the bylaws, there's a paragraph that describes what this committee is about. And I'll read it real quickly. It's to evaluate and make recommendations to the board related to graduate medical education program, medical research and publications, physician engagement, and continual support of medical staff and resident programs at JPS, which is really awesome. I mean, and it's broad enough to drive a Mack truck through. So let's all get in a Mack truck and just drive right through this and push the envelope in terms of what we can do. We have the chairman of the finance committee who said he's going to write big checks to do all the important things that to make the investments. That's what he always says when I ask him for money. But let's push the envelope and give the support that this group needs and really make. There's investments that we need to make internally for our infrastructure to support this. I know the chairwoman is supportive of this 100%. I met the new president of UTA, Arlington, and I told her I learned that they're seeking to build in the near future a health sciences building. And I said, I know where you can build it. That's the kind of stuff that we need to leverage, right? Those kinds of relationships and figure out how we can reach out to partners. Charlie, let's call Bashini at TCU. I know some land. We got some land. We build a medical school, right? Let's do those kinds of things to just push further and further. And I think everybody here on this board and our chairwoman will support it 100%. So if anybody else has any thoughts like that, I'd love to hear them. I know Dan Casey's really hard to get to talk or even care about residents or anything like that, but
I called it troublemaker earlier.
Troublemaker, yeah. Well, this is going to be the troublemaker committee.
I do. Being competitive in the market for retaining is an issue. DFW is not getting smaller, and I think we're seeing that. Maybe Dr. Becker will speak to it at some point in a future meeting. But things like overpayment and Dr. Elliott mentioned, designation go a long way. As someone on the front lines doing the recruiting, I do appreciate the support to now go on the road again, and it's been successful over the years with our national reputation. And yeah, we've learned how to do it in video, and that's been wonderful with COVID, but there's nothing like being in person and really invest on that. And we did have quite a few trips planned pre-COVID, and we're pretty excited by them actually, and we don't give up on that energy right now. But that's a little bit of investment time, personnel, and on just to see that, because those aren't exactly billable hours and things of that sort. But it does pay off. And, I'd love to see buildings go up too, so I'm very appreciative of those comments.
Awesome.
I'm sorry? I can't, sorry.
In population.
Oh, okay, yeah.
By 2030, I think, in 8 years. So
Our
a lot of growth.
I don't think there's any. They are, and we want to maintain them.
I would think one of the things that we would want to look at is identifying our future needs for the, not just family medicine, but in order for us to support the system, we've got to be able to refer our patients to see a specialist when the doctor says as soon as possible, that is not 2 months. So I'd like for us to, part of this education, what all we're doing with, look at that, because we have a neurology clinic and we have this, but I'm not sure we've ever looked to see what we actually need to make it more efficient and effective for our patients. Because it's not okay for the doctor in the emergency room or the family, your primary care doctor to say, you need to be seen as soon as possible, and soon as possible is 2 months out for a specialist. And so I think if we could look at the whole system and identify what we actually need, then come up with a plan how we can get there.
Absolutely. And I think that's definitely something that I know Dr. Duncan and Dr. Becker and I have definitely talked about, and how we can do that. And there's some opportunities we have there, Mr. Bose, to be able to do that. And I think build some programs also to help.
Right.
With that.
Right. Okay.
Any other thoughts and comments? We don't have anything closed.
Mr. Chair, I appreciate the board engaging and, supporting this endeavor. It is incredible. It's so important for our patients, for our community, our providers, and the future of medicine is really important. And I think we're proud of what we do. We take an incredible responsibility in that, and we appreciate all the efforts for you to support this. Thanks.
Glad we have this committee.
Yeah, thank you, Madam Chair, for
Well, I told
reenacting this
you.
committee.
I tell you, it's going to be exciting.
Get your popcorn ready.
It's going to be exciting for 2 years.
All right, thank you, Dr. Elliott. Any closing comments?
I just want to also just echo my appreciation for everyone here. These are great ideas. These are things, the feedback, and I love the collaborative nature of this committee to be able to just kind of be that sounding board too also. And also I really appreciate the advocacy for what we do in education here, and not only just here locally, but beyond. It's important. And I just want to just thank you for that. And if there are those areas that you feel, I'm looking at that one paragraph, and I'll bring forward anything else that you need for the future meeting. If there are specifics that come up, please feel free to.
I'm going to add et cetera.
As a program director, I too would like to thank you all for re-engaging this committee. I really appreciate this opportunity, and also thank Dr. Elliott for all her years of leadership and setting a good example and advocating to get our residents' salaries up to market value. That was huge too. And so therefore, thanks to previous finance chairs for helping us with that as well.
Oh yeah, it's definitely.
So thank you all. Thank you very much.
And for future, we'll, as I told you, we had those 5 areas, and we'll bring forward some research in the next time,
Great.
if you'd like.
And please funnel all the input you can, so we'll make sure our agendas are full and robust, and that we're covering things people want to talk about.
We plan on being here to 7 p.m. Yeah, okay.
Give us more
Yeah, he's cutting out the meals. All right.
That's right. I just say this, if we can accomplish some of this is great stuff.
Yeah.
Hell, I'll stay to 7 o'clock.
There you go. There you go. I like that, John.
Without dinner.
Without dinner. You take my dinner.
All right. Without further ado, I think we're adjourned. Thank you all.
Thanks.
Yes.